All right, Chapter 17, cardiovascular emergencies. This will probably be by far the most common medical emergency you guys will run on. Heart disease, America's #1 killer, probably always will be. Heart disease that people have, whether they know it or not, can lead to them having chest discomfort. It also can cause them to go into cardiac arrest as well. So you've got to make sure that you know the signs and symptoms of cardiac compromise and be able to recognize those and make sure that you treat appropriately. So the circulatory system has 3 major components. The heart, that's also considered the pump. The blood vessels, that would be considered the container. And then the blood, which is the liquid that flows through the container or the blood vessels. There also is an electrical system that is within your heart muscle itself, and this is going to stimulate the cardiac cells to actually contract to produce a pulse. You have 3 different pacemaker sites in your heart. The one that should be dominant from the time you're born to the time you die would be your sinoatrial node. The next picture shows where this is located. The intrinsic rate, and what I mean by intrinsic is the normal rate for the SA node is somewhere between 60 and 100 beats per minute. Now, certainly it can go slower than that, and it can also go faster than that as well, but the inherent rate is going to be between 60 and 100. If that fails, then the atrioventricular or AV node is going to pick up the slack, we hope, and now that will become the dominant pacemaker if the SA node fails. The intrinsic rate of the atrioventricular node is going to be between 40 and 60 beats per minute. And then if that fails, then the Purkinje system or the Purkinje fibers is going to hopefully kick in. And the intrinsic rate for that is going to be somewhere between 20 and 40 beats per minute. So here is the conduction system of the heart. Again, this is where your SA node should be. Your AV node is right down here and right here, I'm sorry. Between the SA node and the AV node, we have what are called intranodal pathways, and this just connects the SA node to the AV node. The big reason the AV node is there is whenever this SA node fires, we'll say 60 times per minute, when it fires, it goes through this internodal pathway to the AV node. This AV node is holding that stimulus for less than 1/5 of a second before it makes it down into the bundle branches and into the Purkinje system. That is to prevent the ventricles and the atria from beating at the same time. All right. So once it makes it through the AV node, it's going to go into the bundle branches. You have a right bundle branch, you have a left bundle branch, and then it's going to terminate into the Purkinje system or the Purkinje fibers. The heart has the property of automaticity, and what that means is if you guys are familiar with Christopher Reeve, he played Superman back in the day, and he was in an equestrian accident where he went over the head of his horse, broke his neck, broke his C1 and C2, and was quadriplegic for the rest of his life. So his skeletal muscles, he was never able to regain use of his skeletal muscles after that. His involuntary muscles also were never able to recoup from that. However, his heart just kept going and kept going and kept going. So that kind of shows you how the heart itself has the property of automaticity. Now, it can be influenced by the sympathetic and the parasympathetic nervous systems. So if someone comes up and puts a gun in your face, then your sympathetic nervous system is going to become dominant at that point. Your heart rate is going to increase. The contractile force is going to get stronger. But when you go to bed at night and you're asleep during the night, then your parasympathetic nervous system is dominant at that point, and your heart rate will slow. Your contractile force of the heart will decrease as well. So the heart has got to pump blood. The right side is only responsible for pumping blood to the lungs and back. The left side is responsible for pumping blood everywhere other than the lungs. So that being said, the left ventricle has got to be a lot stronger and a lot more muscular than the right side because of it has to pump blood from the top of the head to the bottom of the toes. The left ventricle has got to overcome the pressure in the aorta to be able to eject blood from that ventricle. So if you have a patient that has high blood pressure, whether they know it or not, that left ventricle has to work harder to pump blood out of the ventricle against that pressure that's in that aorta. When this happens, that's one of the leading causes of having heart failure is you have excessive pressure, you have high blood pressure that is causing that left ventricle to have to go into overtime, and it can cause damage to that left ventricle. Excuse me. Okay, so let's just trace a drop of blood through the heart here. Everything in blue that you see here, this is something that's venous. The things that are in red are going to be arterial. So the blood comes into the right atria from the superior vena cava, and then from beneath the heart from the inferior vena cava. Now remember, all this is deoxygenated blood. Everything on the right side of the heart is going to be deoxygenated. The blood's going to come into the right atria. It has to go through a valve here. This is called the tricuspid valve. The reason it's called that, it's got 3 little flaps on it, and it's going to go down into the right ventricle. When the right ventricle contracts, the blood is going to be forced up into the pulmonary artery. Now, there is something very significant about this pulmonary artery. This is the only artery in your body that does not carry oxygenated blood, right? The only artery that does not carry oxygenated blood. You see a valve here. This is called the pulmonic valve. The reason that valves are in your heart is to keep blood from backwashing from where it came from. So we go out through the left and the right pulmonary artery out here into the lungs. The blood picks up oxygen, gets rid of carbon dioxide. It comes back to the heart, now oxygenated, into the pulmonary veins. The pulmonary veins are the only veins in your body that carry oxygenated blood. The blood's now going to go into the left atria. There is a valve here called the bicuspid valve, also known as the mitral valve. Again, to prevent blood from coming back up into the atria once it makes it down into the ventricles. Makes it down into the left ventricle, then it's going to go, again, be forced up into the aorta. It has to go through the aortic valve to get to the aorta, and then, again, it goes to the top of the head to the bottom of the toes. These 2 valves, the tricuspid and bicuspid valve, those together are called the AV valves for atrioventricular valves. And then the pulmonic valve and the aortic valve, those together are called semilunar valves. So here we have a picture of, again, this is the right side of the heart. So this deoxygenated blood is coming back to the right side of the heart. It gets pumped out, again, deoxygenated to the lungs. It picks up oxygen, comes back to the lungs. Now we're oxygenated, and then where we have the capillaries, this is where the carbon dioxide and CO2 is exchanging places in the capillary beds. So the blood vessels are the arteries. You can certainly say that all arteries take blood away from the heart. Now, not all arteries carry oxygenated blood, but all arteries take blood away from the heart. Those will branch off into smaller vessels called arterioles. Then bringing blood back to the heart, we have veins. Those will branch off into smaller vessels called venules. And then where the arterioles and the venules meet, that's the capillaries. And that's, again, where the oxygen carbon dioxide exchange will take place. All right, so these are your major arteries. The ones that you really need to be familiar with, I'll just work from the head down. The one in the neck, we don't really deal too much with the temporal. There's not really much we can do, as far as assessing or whatever with the temporal artery. But with the carotid artery, again, very important, very major vessel in your body. If it gets lacerated with, you go to a knife fight and it gets lacerated, then you can certainly bleed out very quickly. Coming down here into the arms, we have the brachial artery, which is in the upper arm, and then coming down here on the thumb side, we have the radial artery. Of course, we have the aorta that is coming up out of the heart and taking blood to the head, and then the descending aorta that takes blood to the lower extremities. Here in the groin area, we have the femoral artery. Behind the kneecap, we have what's called the popliteal, and you guys that were in the military, I'm sure you were told to never stand at attention with your knees locked. The reason being is you're probably going to pass out if you do that, because the arteries and veins behind the knee will be constricted and you're not going to get enough blood flow back to your heart. Then on the top of the foot, we have the dorsalis pedis, and then right behind the ball on the inside of your ankle, right a little bit inferior and posterior to that, you have what is called the posterior tibialis. The veins, guys, if I was you, I would say the biggest veins you need to really be concerned about are going to be the inferior and the superior vena cavas. Now, the heart muscle itself has got to have perfusion as well, and so those are called the coronary arteries. So whenever these are occluded with plaque or cholesterol or whatever, probably due to several things. It could be your hereditary, it's one thing you can't pick is your parents. So if there's a heavy heart disease history in your family, then probably you have that as well. It could be your lifestyle. It could be the diet that you have, the sedentary lifestyle that you have, smoking, diabetes. So some of these are modifiable, some of them are not. Then you can have plaque built up in the coronary arteries, and that is going to cause you to either have a heart attack, you can have heart failure, or you can have abnormal cardiac rhythms. So here we have the coronary arteries. You have your right coronary artery that you see here, and obviously this is going to pretty much feed the right side of the heart. You have your left coronary artery. These are the two main arteries that are your coronary vessels. Now these do branch off, like there's one that you don't see here that goes all the way around your heart, kind of like the equator. That's called the circumflex. One of the real big ones is this left coronary artery that comes down over your left ventricle. That kind of feeds your left ventricle, and that's a big issue if you have that one occluded, because you're depriving the largest, most muscular compartment of your heart to be deprived of oxygenated blood, and it can start to fail. Something else that you notice about this is, probably ever since you sat in a classroom, you were taught that the bottom of anything is called the base, and in the heart, that's not the case here. You notice that the base, or the bottom of the heart, is called the apex, and the top of the heart is called the base. Now, there's a lot of components in the blood. The red blood cells are also known as erythrocytes, and the big thing that red blood cells do is they're the only thing in your blood that can carry oxygen. So that's its biggest deal, is carrying the oxygen to and from the vessels, or to the vessels, or I'm sorry, to the organs. The white blood cells are also known as leukocytes. Their big function is to fight off infection. Platelets are also known as thrombocytes, and their big key role is to help clot blood. Those three, the red blood cells, white blood cells, and platelets, are called the formed elements of the blood. The plasma is just the water that is circulating these formed elements throughout the vessels and to their specific organs. So platelets play a big role in cardiac emergencies. Let's say that you have well, let me pull up this next slide right here, okay? So here you have a artery that, it's got a little bit of plaque, but that's probably pretty normal for most people. You notice that you've got different layers of this vessel. You have the most inner layer. These are the three layers: the tunica intima through the adventitia. The tunica intima is the innermost layer of a vessel. Just remember, if you're intimate with someone, you're very close to them. So this is the one that's closest to the inside. Tunica media, just think you got a median running down a highway that splits it down the middle. There's a tunica media, and then on the outside you have the tunica adventitia. Now the very inside of that vessel is called the endothelium. So we see a little bit of plaque here. Now we're starting to get a little bit more plaque right here, so we're starting to get a little fat. You've got about probably a 50% occlusion right here. Now it gets even that much worse. Sometimes this plaque can actually calcify. So just think of this as concrete that you just poured and it's still kind of malleable. Whereas if this is now calcified, then the concrete's hardened. And so it's going to take a whole lot more to get rid of this concrete than it would to this concrete. You hope that if this is in your coronary vessels, you hope that this is still spongy because that's a lot easier to reverse than if this is already calcified. So now we have a very significant occlusion right here. Sometimes what can happen is, let's say that the blood is, coming through this vessel right here. Even in a situation like this, we have blood coming through here, and sometimes that plaque can actually just kind of peel away. And when it peels away, it's going to cause that vessel to start to bleed. So now we have a clot that starts to form. Well, if you've ever cut yourself, you know that platelets' job is to go down to that open wound that you have, send platelets down there, and clot that bleed off. Well, a bleed is a bleed is a bleed, and so if the body recognizes, hey, I've got bleed in this coronary vessel, then I've got to send platelets down there to stop that bleed. When those platelets start to hang on to this blood clot, it's going to make that blood clot bigger. So that's why it's so important for you guys to give these patients aspirin as soon as you get there. As a matter of fact, it's so important that dispatchers are now trained to, when someone calls in and says someone in my family is having a heart attack, they'll tell them, if you have aspirin there, go ahead and give aspirin even before EMS arrival. So how the aspirin works is that when these platelets make it down and they find this bleed, it makes the platelets less sticky, so they tend to not aggregate and collect at that clot. Now, you're probably not going to make that clot any smaller, but your goal in giving an aspirin is trying to make sure that that clot does not get any bigger. All right, so when the SA node fires, again, it's going to, that is what causes the atria to contract. Then it goes through the AV node, and remember the AV node is there or pause that stimulus for less than 1/5 of a second before the ventricles are stimulated, and hopefully the ventricles are going to contract as well. All right. Now, when the ventricles contract, that's what we call systole. We will, if we ever get back face to face, we'll certainly show you guys how to hook an EKG up to a patient. We don't teach you how to read one. That's a paramedic skill, and that's a very long, drawn-out part of class is learning how to read EKGs. But we'll at least kind of show you how to hook an EKG up and so forth. But anytime you have an EKG or an ECG run on you, it's just showing nothing more than the electrical activity in the heart. It has nothing to do with the contractile force of the heart. All it is looking at the electrical conduction going through your heart. Now, when you see the word depolarization, just think of that as the word, same word as firing. Whenever you see the word repolarization, just remember that equates to resting. So when the SA node fires, then it just depolarized. Whenever the rest of the heart is depolarizing, then the SA node is repolarizing or recharging. We will put electrodes on the patient's skin, and then we will get something that looks very similar to this come out on an ECG paper. So just a little heads up on what this equates to is this is what is called a P wave. This corresponds with the firing of the SA node and the atria contracting. This is the Q wave right here coming down. This wave coming up and coming down is the R wave. And this wave coming back up is called the S wave. So this whole thing is called the QRS complex. This correlates with the ventricles contracting. And then this is the T wave, and the T wave is indicative of the ventricles actually repolarizing. Okay. Now, what we missed is, okay, depolarization of the atria, depolarization of the ventricles, repolarization of the ventricles, but we somehow missed the repolarization of the atria. The repolarization of the atria is hidden in the QRS here. All right. You can't see it. Okay. So how do you know it's there? Well, it's like the spirit of Christmas. You can't see it, but you know it's there. So it is buried in here, but it's not visible. Let me talk about this T wave real quickly as well. Okay. National Registry has been asking questions about this. So please be familiar with this. You notice the T wave looks like a small hill. So we have the up slope of the T wave, and then we have the down slope of the T wave. The up slope of the T wave is called the absolute refractory period. What that means is nothing intrinsic mean inside your body or anything extrinsic, anything that's outside your body. If there's a stimulus that lands on that upslope of that T wave, that should not change this rhythm at all. However, the downslope of the T wave is called the relative refractory period. So if you have something intrinsic such as this guy, this QRS decides to fire over here before this thing is repolarized, that would be something intrinsic. Something extrinsic would be if you got hit in the chest with, a steering wheel, you're in a car wreck and you went into the steering wheel. If you were hit in the chest with a baseball, something of that nature, and it landed on the downslope of that T wave, then that can change this rhythm into a lethal dysrhythmia. All right. If that happens from an outside force, it is called commotio cordis. It is Latin. I'll spell it for you. It's COMMOTIO, another word, cordis, CORDIS. And so when you have a sudden either death or a sudden change in the rhythm due to an outside force hitting the downslope of that T wave, then that is called commotio cordis. Now, hypoxia or damage to the electrical conduction system can cause the functioning of the heart to not work properly. You can have a very uncoordinated firing of the ventricles that can lead to what we call premature ventricular contractions, or PVCs. We can have someone that goes into ventricular tachycardia or ventricular fibrillation. So let me go back to this slide real quick, and I'll kind of show you what you would see with VTach or VFib. So hang on just a second. All right. So here we have, let me go back a couple more slides. Okay, so here we have the heart that we've transected. All right, if you have a premature ventricular contraction, remember the SA node should fire. It should come down through the internodal pathways to the AV node, and then it go into the ventricles. If the ventricle, because it's irritable, decides to fire before that SA node fires for the next beat, okay, then that's called a premature ventricular contraction. We can have something called ventricular tachycardia. That means that nothing up here above the ventricles is working anymore. That means the ventricles themselves are firing without any help from the atria at all, from the SA node or the AV node. The ventricles are firing on their own, but the heart rate's going to be above 100. Now, you can have somebody in VTach and they can be alive, and if they're alive, they can be perfectly stable or they can be very unstable. You also can have someone who is in VTach and they can be dead. So Obviously, checking a pulse will be one of the most important things that you're going to do on someone that you suspect has got VTach. Now, VFib, again, everything above the ventricles is failed. What's going on in the ventricles? Just think of you got a sack and you fill it full of worms, and you see those worms wiggling inside that sack. That's about what VFib looks like. Okay, so the ventricles are just sitting there quivering. There will be no pulse ever with VFib. So the VTach and the VFib, those are the two rhythms that when you hook an AED up to a patient, then that's what the AED is going to recognize as a shockable rhythm. All right. Okay. So let me go back to where we left off here. Okay. So hopefully that explained well enough about what PVCs, VTach, and VFib look like. Now, blood pressure. Whenever you check someone's blood pressure, that is during the contraction of the left ventricle. The top number that you're going to get, or whenever you hook a blood pressure cuff up to a patient and get your stethoscope out, and you're listening for a blood pressure, the first big thump that you hear, that's their systolic blood pressure. All right. You're going to hear several thumps as the gauge is going down on the blood pressure cuff. When you hear that last thump, then that's the relaxation of the left ventricle, and that is what's called the diastolic pressure. So really all the blood pressure is the degree of resistance of blood vessels, and how much resistance is there in the blood vessels that are going to affect the blood pressure. Now, several things can affect the blood pressure. Again, if you have cholesterol, or you've got a family history or something like that, a high blood pressure, then you can't really do anything about the hereditary, but you can certainly do things about the diet that you have. All right, high blood pressure can be caused by your heart rate going too fast. It could be your heart is contracting too hard. So there's several different things that can cause someone to have high blood pressure. About 75% of people that have high blood pressure don't know that they have high blood pressure. They typically don't know they have high blood pressure until they start seeing other signs and symptoms like nosebleeds or headaches, or they just go get their blood pressure taken and it's 170 over 110, and they've never had any signs or symptoms associated with that. So again, the top number is going to be your systolic pressure. Bottom number will be your diastolic pressure. 140 over 90 is considered too high. But one thing that you need to remember when you're taking blood pressures is you need to find out what's normal for that patient. For example, you may have an 80-year-old female and you take her blood pressure and it's 110 over 70, and you're thinking, wow, that's a really good blood pressure for your age. Well, it may not be. You need to ask her, man, what does your blood pressure normally run? And she says, normally about 160 over 100. That's what it runs every day? Yes. Okay, well, 110 over 70, that's very hypotensive for that patient that normally runs 160 over 100. Don't be surprised if you have some very well-toned athletes. You check their blood pressure, and their normal blood pressure day in and day out may be 90 over 60. So you need to make sure that you have the right, or that you know what the normal blood pressure is for that patient. Also, please make sure that you put the right size blood pressure cuff on a patient. Most ENTs just put one size fits all on everybody. That doesn't work all the time. Your blood pressure cuff should cover 2/3 of the upper arm. If you have too narrow of a blood pressure, you're going to get an inaccurately high reading. If you have a too wide blood pressure cuff, then you're going to have an abnormally low reading. So you need to make sure that you have the right size cuff that you're putting on the patient. Me personally, when people were using the wrong size cuff on me, there was a 20 millimeter difference in the systolic, especially the systolic, versus using the right size cuff for me. So When I have it taken with the right size cuff, it's 110/70, but then when I have a cuff that was too small, then instead of 110, it's in the 130s. So please make sure you use the right size cuff. Now, inadequate circulation. That results in what we call hypoperfusion, and it's also known as shock. So when you don't have enough blood flow getting to the target organs, the cells have got to have oxygen, they have to have nutrients, and they have to be able to get rid of waste. Well, if you don't have these cells that are able to make it to these target organs, then obviously they're not going to be as oxygenated, they're not going to have as many nutrients, and they're not going to be able to get rid of waste like they should. This could result from someone being hypovolemic, and what that means is they don't have enough volume anymore. This could be a gunshot wound to the liver and they're bleeding out. This could be someone who's had 3 days of vomiting and diarrhea. This could be someone who is dehydrated. So there's several ways how you can become hypovolemic. They can have heart failure. Again, let's talk about the left ventricle. If you have a heart attack in that left ventricle, and that left ventricle was at 100% pumping prior to this heart attack, and now you're only at 50%, then obviously you're not going to be able to get as much blood flow circulated where it needs to be. Or you can have a problem with vasodilation. When you get let's say you get an ear infection, you don't get the ear infection taken care of, and now that ear infection becomes an infection of the blood, and you become septic. When you get septic shock, that's going to cause your vessels to dilate. If you have a spinal cord injury, the spinal cord is the pathway between the brain and everything south of the brain. So if that pathway is interrupted due to a spinal cord injury, then the vessels are inherently lazy, so they would much rather dilate than constrict. So when you just narrow this down to very easy terms, there's 3 things that can cause hypoperfusion. You got a pump problem, which is your heart. You have a volume problem, which is your blood or your water in your blood. And you have a container problem, which is your vessels. Cardiac emergencies are a big problem. So what we can do is we can treat them as quickly as possible. And there's an old saying that time is muscle. The longer that they're having this cardiac compromise, the more muscle that is being consumed in the myocardium. It's unfortunate that most people, especially first-time people having cardiac compromise, they're in denial and they wait way too long to call for EMS or take themselves to the hospital. So the sooner that they call, the sooner we can get them to the hospital, the sooner we can get them to definitive treatment, the less muscle is being consumed. So collectively, all the cardiac problems that that a patient can have are called cardiac compromise. Again, the sooner we get to them, the better off they're going to be. All right, atherosclerosis. This is where you have plaque buildup in your arteries. All right, typically this is the medium to larger arteries where you get atherosclerosis, but you can certainly have it in your coronary vessels as well, and that's known as coronary artery disease. So let's say that all you do is sit on the couch and play video games, and you eat a horrible diet, and you go get your cholesterol checked, and your low density cholesterol, your LDL is 300. Your HDL or your good cholesterol is 60, so you have a 260, 360 cholesterol count. All right, you're going to have some plaque buildup in your vessels. So you decide, okay, I'm scared. Let me go outside, start exercising. Let me clean my diet up. The higher you can get your high density cholesterol, the better, because that helps sweep away the lower density cholesterol. Your cholesterol goes down below 200 where it should be. You may no longer have atherosclerosis. You may no longer have coronary artery disease if you can get all that under control. Now, acute coronary syndrome, this includes what's called unstable angina, and angina is nothing more than a mismatch of oxygen supply and oxygen demand in the heart. So if your demand and your supply are equal, or you have more supply than you do demand, then you should not be having any kind of chest pain. However, if your demand exceeds the supply of oxygen, then that's when you can have what's called angina. Now, the word myocardial infarction. All right, let me just break this word down for you. Myo means muscle, cardial means heart, so the heart muscle, and then the word infarction means death thereof. So you have death of the heart muscle. So if it dies, it's not coming back. You can have angina your entire life and never have any permanent damage to the heart. But if you have an MI, then you have damaged your heart at that point. The narrowing of the coronary vessels is what leads to having myocardial ischemia. Ischemia is basically the same thing as you having the chest pain associated with angina. You have more demand on the heart than you have supply of oxygen to the heart. All right. So the most common chief complaint that people have when they start to have cardiac ischemia is they have chest discomfort. It can be described as pressure. It can be described as an elephant sitting on my chest. So it's more of a dull, achy pain than it is a sharp pain. Okay, so as I said, angina pectoris or angina is a result of reduced oxygen delivery to the myocardium. This typically is going to result in them having chest discomfort. It oftentimes comes from physical or emotional stress. And guys, when we have that, that's called stable angina. So let me just talk about that for just a second. I'm sitting here watching TV, watching the Golf Channel, and I'm just about as relaxed as I possibly can be. I'm doing great. I look out my back window and I go, man, I need to go out there and mow the yard. So I go out, I crank my lawnmower up, and I get 2 or 3 rows into my mowing. Okay, what happened to my demand on my heart? It went up because I'm exerting myself now. What happened to my supply? My supply can't keep up with that demand, so I start to have chest pain. So I stop mowing. I come in, I sit back down in my recliner. My heart rate is going to come down. I'm no longer exerting myself, so my heart rate is going to come down. So the demand on my heart is going to start to come down as well. The supply now meets the demand. The chest pain goes away. No damage to the heart. Okay, it's kind of like if you were to put a rubber band around the last knuckle on your finger till your finger turns purple. All right. Okay, you've got a decreased amount of blood flow getting down to the tip of that finger. Now you take that rubber band off and that finger turns pink again. There's no damage to the end of your finger. Okay, so that's called stable angina. So stable angina is typically resolved with rest, or the patient may have some nitroglycerin. That's going to cause the coronary vessels to dilate. That's going to get more oxygenated blood down to the myocardium, and that should help the chest pain go away as well. All right. The unstable angina is I'm sitting there watching the Golf Channel at rest, no chest pain whatsoever, and all of a sudden I start to get chest pain. All right. Well, I'm about as rested as I can be, so now I pull my nitro out of my pocket, pop a couple of nitro tablets, and now my chest pain goes away. So bottom line is angina pain typically will go away with the use of nitroglycerin. If you're having a myocardial infarction or a heart attack, chest pain typically does not go away with nitroglycerin. All right, so this is showing we have an occlusion right here. This is the anterior descending part of the left coronary artery. This is the one that feeds your left ventricle here. So everything south of this occlusion right here, you start to see is starting to be oxygen deprived. So there's about a 12-hour window from the onset of chest pain to the time they need to be in definitive care, whether it be they get what's called an angioplasty. They go through their femoral artery. They'll take a catheter. They run all the way up to your heart, and they find this vessel right here, and they'll stick this catheter into this vessel, all right, and then they inflate a balloon, and it smushes all that plaque off to the side of that vessel, and then they come along and they put what's called a stent, what's kind of like the spring in a ballpoint pen. They put it in there, and that keeps the plaque from unsmushing and filling that coronary vessel up again. Sometimes people are absolute train wrecks when they get in there, and angioplasty is not even an option. So what they'll do is they'll do what's called coronary artery bypass graft surgery, or CABG, and they'll take a vein from your leg, and they come up here and they just cut that vessel right there, and they bypass this area where the infarct is occurring, and they just bypass that and connect with the vessel down here. So if we can get them to definitive care, unless they're just having a massive MI, if we can get them to definitive care within 12 hours, then there may be absolutely no permanent damage to this area whatsoever. So the sooner we can get them to the cath lab, the less muscle is being consumed. So this patient, if they call as soon as they get chest pain, we go out, we give them aspirin, we put oxygen on them, we give them nitroglycerin, we get them to the cath lab in 15 minutes. After we pick them up, within 10 minutes, they've got that balloon in there. They're probably going to go home to their families in a couple of days, and there's no permanent damage to the heart. So when this, again, as I said, with the angina that's prolonged or worsening, that occurs without exertion, and that's what's called unstable angina. This is also known as non-exertional angina. The stable angina is also known as the stable angina is also known as exertional angina. All right, so let's just kind of compare the two here, okay? On the left-hand side, you've got angina. On the right, you've got an MI. So the location of discomfort will probably be the same, either substernal or across the chest with both of them. They can radiate. Now, the MI is probably going to be more likely to radiate than the angina will, but it can go up into the neck, the jaw, the arms, the back, the shoulders. Basically, anywhere between the clavicles and the belly button, if they're having pain, it needs to be considered cardiac until proven otherwise. With the angina, again, it's probably going to be about the same as with the MI, like the dull or heavy pressure on the chest. However, if it's not relieved with nitroglycerin, then it's probably an MI, not angina. Usually your angina will last, no more than 15 minutes, whereas your MI pain is going to last longer than that. There's usually no other symptoms with angina, but with an MI, they may perspire, they may get diaphoretic, and it's usually kind of a cold sweat. They may become pale or gray. They could get nauseous and vomit. They may be dizzy. Precipitating factors of angina, if it's stable angina, then obviously you exerting yourself would be a predisposing factor for that. An MI can occur at any time. It can occur in your sleep. And guys, that's a huge deal. If someone calls you at 4 o'clock in the morning with chest pain and they tell you that it woke them up from their sleep, that's huge if it woke them up from their sleep. So they're probably having an MI, not angina. Factors that give relief, typically if they stop the activity or they take nitro or both, with the angina, the pain will go away. However, with the MI, then you're probably not, you may get some relief, but the pain's not going to go all the way down to a 0 like it would with angina. The reason that women are more likely to die from a MI is the fact that they tend to underreport their signs and symptoms. They have more important things to do than to deal with an MI. They have families to run. They have husbands to take care of, children to take care of. They have work duties that they have to do. And they tend to underreport their symptoms to not only us, but even more so to the physicians at the hospital. And if they don't tell the true story and all of the story, then they don't get the same tests that the people that just spill their guts and tell them everything that's going on. So I think everyone knows that women are a lot more pain tolerant than men are. So they tend to kind of downgrade or downplay the pain that they get. So if you're a woman, if you're a diabetic, diabetics tend to have what's called neuropathy. They don't feel things quite like they used to before they were diabetics. And I think it's pretty commonly known that the elderly have more pain resistance than or pain toleration than the younger folks do. So you look at the top, you've got the trifecta there for having what's called a silent MI. You've got a woman who's a diabetic and she's postmenopausal. They may have no signs and symptoms whatsoever of having any kind of cardiac compromise. They may be complaining of, I feel weak, I feel dizzy, I just don't feel right. I can tell you that old people do not want to go to the hospital unless absolutely necessary, because they're afraid that they won't come back home, that they may be sent to a nursing home. People die in the hospital, so they're afraid they may die if they go to the hospital. So, but if you have an elderly person that just has these real vague signs and symptoms, I just don't feel good, but I really want you to take me to the hospital, that's a huge sign if they're requesting you to take them to the hospital. All right. Okay, so what do we do for angina? Well, if their sats are below 94%, it just really depends on how far below 94% that they are. On do we want to give them a nasal cannula or do we want to go with a non-rebreather? So in 2010, American Heart came out and they said that if the oxygen saturation is 95% or above and they're having a heart attack, then they do not need supplemental oxygen. Only if it's below 94% do they need supplemental oxygen. All right. If the patient has their own nitroglycerin and it's theirs, it is prescribed to them, and they're having chest pain, and they have a blood pressure of at least 90 millimeters of mercury, and they have no other contraindications to giving nitroglycerin, then we can give the 0.4 milligrams of nitroglycerin, whether it be spray or whether it be a tablet. With the aspirin, most likely the aspirin that you carry will be either low-dose aspirin or baby aspirin. They are 81 milligrams a piece. So you're either going to give 2 of those, which would be 162 milligrams, or you're going to give 4 of those, which would be 324 milligrams. If you carry just a regular old adult dose aspirin, that's going to be 325 milligrams. Aspirin is not a vital sign dependent drug, meaning that as long as they're not allergic to it, as long as they don't have an active stomach bleed, then you can go ahead and give them aspirin even before you take vital signs. But it is imperative that you take vital signs before you give nitroglycerin. Okay, so when that plaque ruptures with an MI, then a thrombus is going to start to form, and within 20 to 30 minutes, the heart muscle is going to begin to die. And guys, the key word here is begins. It's not dead yet. We're all dying. As I sit here, talk to you, we're all dying very slowly. So the muscle's not completely dead yet. That's why time is of the essence, that we get the patients to definitive treatment as quickly as we can. So our goal is basically just kind of twofold. We're not doing much anything to reperfuse them. Our goal is kind of threefold actually. We want to give them aspirin to try to prevent that clot that is formed from getting any bigger. We want to give them nitroglycerin so we can do 2 things with the nitroglycerin. The nitro is going to vasodilate the coronary arteries. So when we vasodilate the coronary arteries, we're getting more blood flow to the coronary muscle or to the cardiac muscle. But we also have systemic vasodilation as well. So when you've got less blood coming back to the heart, that's going to decrease the demand on the heart, and that should decrease the size of the infarct that is occurring. And then obviously if the O2 sats are below 94%, we need to provide supplemental oxygen as well. All right, so we have seen that slide. Again, we've seen this one. So the diabetics, the elderly, If you're a woman, again, there's the trifecta for having what's called a silent MI. So as an EMT, it's extremely difficult to determine, okay, if she's not complaining of chest pain, then how do I know if I'm supposed to give her nitroglycerin? In paramedic school, you'll learn other techniques and how to assess a patient, and so it should be pretty clear as a paramedic if you can give nitro or not. But it's pretty gray on the EMT level on do I give nitro or not with these silent MIs. Okay, make sure that you realize that people can go into cardiac arrest from cardiac compromise, so have your AED ready. Remember, the VTAC and the VFib are the two rhythms that AED will recognize as a shockable rhythm. Manage their airway and their breathing, and again, administer oxygen based on what their oxygen saturation levels are. All right, so if they have nitroglycerin, again, blood pressure has to be at least 90. They have to have no contraindications such as a bleed or a head injury. They cannot have taken any of the erectile dysfunction drugs within the last 36 hours. You guys probably have the tablets. So whether you have the tablets or whether you have the spray, they're both 0.4 milligrams. You can get that every 3 to 5 minutes as long as the pressure is above 90 and as long as they're still having chest pain. You can get that every 3 to 5 minutes up to 3 doses. If they're not allergic to aspirin, they don't have an active GI bleed currently, then you can give the aspirin as well. Aspirin typically is given prior to nitro because you do not have to get vital signs to give the aspirin. Make sure that you notify the facility as early as possible. You guys, you have the luxury of being there with paramedics, so you don't have to request an ALS intercept. ALS is with you already. And so they have, these hospitals are mandated that from hospital notification time, so from the time the medic calls the hospital and says, we're calling a code STEMI, or we're bringing someone with chest pain in, they have 120 minutes or 2 hours to get that patient into the cath lab. Once you hit the emergency room door, then they're mandated to have that patient in the cath lab and ballooned within 90 minutes. Now, there is talk that they're going to change that to where instead of hospital notification to balloon time, they're trying to decrease that from 120 minutes down to 90 minutes. All right, so an aortic aneurysm, you can have, typically you either have a thoracic aneurysm or you have an abdominal aneurysm. So your aorta is a very, very thick-walled vessel because, again, it has to take blood a long way. So when you have a bubble that forms on your aorta, just think of the last time you went tubing down the river. You're the one that got the inner tube that had a big bubble on it. Well, think of that as you're laying around in a aorta and it blew a bubble in it. So you have a lot more aortic aneurysms than you do the thoracic aneurysms, but this is what it may look like. Again, here's your bubble. Okay, that obviously is the best of these two. All right. Just a little history, I guess, about aneurysms. Most aneurysms, whether it be this one or whether it be this one probably not the case, but this guy right here, first off, this can be in your body up to 5 years and you never know it. So how are most of these found? Most of these are found by mistake. You go to the doctor and you are complaining of difficulty breathing. He does a chest x-ray on you and he sees something like this, okay? Or you go get a body scan because the department sends everybody to get a body scan. Oh my gosh, this guy's got an abdominal aneurysm. So most of these are found by mistake, okay? They're looking for something else when they find these. So these can lay in your body up to 5 years and before they'll do this, all right? So let's say that they find this, okay? If they find it like this, that's a pretty easy treat for them, all right? What do you think is going to happen here if you've got a very large vessel that just completely blows open like this? You have a huge problem, Okay, you're going to bleed out very, very quickly. All right. Now, somewhere between this and this, we have what's called an aortic dissection. So let me go to the next slide and I'll show you what this looks like. So again, here is your vessel that we talked about earlier. Remember, you got your tunica intima, which is the inner lining, your tunica media, which is your middle, and your tunica adventitia, which is your outer layer. And then this yellow part, this is the inside of this yellow part is called your endothelium. So you see right here that this tunica intima actually broke open, and you not only have blood channeling through the lumen of this vessel, but you also have blood channeling through here. Well, this can leak. It's probably not going to blow like we saw earlier, but this can actually leak. So let's say that you have one of these, either one like this, or you have one like this in your descending aorta or your abdominal aorta. And what separates the thoracic aorta from your abdominal is your diaphragm. So anything above the diaphragm is considered thoracic. Anything below the diaphragm is considered abdominal. So if you have a dissected one, all right, just think about where that blood's going to drip. That blood is going to drip down onto your rectum. All right, and it's going to kind of put pressure on your rectum, so you're going to have the urge to defecate. It's kind of like when a woman is third trimester pregnant and that baby starts to drop. That baby's head is putting pressure on mom's rectum, and she has the urge to defecate. All right. You need to make sure that you check their femoral arteries as well. Okay, so check your femoral artery should be your second strongest pulse pressure point in your body behind your carotid. So you check the radials and you're going, oh, wow, she's got great radial pulses. You check the carotid, got great carotid pulses. And then you check the femoral pulses, you're going, wow, these are really faint. They're really, really weak. They probably have an aneurysm, all right? Peel the back of your glove off. Check the temperature of their legs. If they're cooler than the upper extremity, then, again, you got decreased blood flow. They very well could have an aneurysm, all right? People always talk about a pulsating mass. You may look at their abdomen and there's a pulsating mass in their abdomen. Don't always expect that. Just because it's not there does not mean that they're not having a dissecting, an abdominal aneurysm. So just because that pulsating mass is not there does not preclude them from having an aneurysm. They probably will be complaining more of back pain than they would abdominal pain if they had an aneurysm in the abdominal area. So you need to remember this. What's going to take care of this is going to be surgery. So you need to make sure you go to a trauma center if you suspect that they have a abdominal aneurysm or a thoracic aneurysm, either one. Again, if you have one that's blown, you're kind of, time is not on your side at that point. So the good thing about trauma centers in Dallas is more and more of these hospitals are stepping up to the plate and becoming trauma centers. So there's a lot more available now to you guys than there was 30 years ago when I started. All right, now I'm going to get on a soapbox here because it's happened to a family member. I'm going to encourage all of you to do this if you possibly can. And, if only one of you does it, then I'm happy for all of you. But there's really not much in here about a thoracic aneurysm, but that's what my mother-in-law died from 7 years ago. She had been complaining of some back pain, and her primary care physician just really couldn't figure out what was going on with her. So he sent her to a pain management doctor, and the pain management doctor had her on injections and oral medication and so forth. And so in April of 2013, she was sitting at home and she started having some chest pain that she'd never had before. So she called an ambulance. The ambulance came and picked her up. They did everything they were supposed to do in the ambulance. They get her to the hospital. They do a complete chest pain workup on her. They're not really finding anything, so they took her back for an MRI and brought her back to a room. And before the MRI got read by the radiologist, she raised up in bed, screamed, and then died right there in her husband's arms. She had a thoracic aneurysm. It just blue. Okay. One thing that you can do that I don't think ever got done to her was you can check blood pressures in both arms. And on the systolic side, if there's 15 millimeters of mercury or more difference between the right and the left, you need to assume that they have a thoracic aneurysm until proven otherwise, and you need to take them to a trauma center. Sometimes, actually a lot of times, it's not just, it's 15 or 20 different. A lot of times it could be, one is 180 on one side and it's 100 on the other side. So there can be some huge differences in blood pressures with somebody with a thoracic aneurysm. So one thing about this tends to run in families. And so all three of my mother-in-law's daughters, one of them being my wife, went and got scanned for this, and none of them, had this occurring, at least at the time. But again, if I can get you guys to check a blood pressure in every single patient you come across, check it in both arms, maybe you'll find one of these thoracic aneurysms that's just kind of laying there latent that nobody can tell. And you saved a life, and you saved someone's mother and someone's mother-in-law and someone's grandmother. So again, I encourage all of you to do this, please. All right, so we talked females. Again, they're more than likely to die, twice as likely to die than men, just because they just underreport their symptoms when they get to the hospital. So they can have the classical findings just like the men, but again, if you're a guy, you're probably going to go, oh, this is a pain of 10 on 10, and the female may have pain even worse than yours, and she's saying it's a 5 on 10. So you need to make sure you keep your suspicions high when it comes to dealing with females who are having chest pain. This is just your very vague symptoms. I just don't feel good, or my fingers are tingling, or something of that nature. So again, keep your suspicions high, especially in your postmenopausal women, 50, 60 and above. Make sure you keep your suspicions high with those folks. Now, there is a reason why we don't give oxygen. We used to think, I went to school in 1981. I was in the same predicament you are right now in 1981. So almost 40 years ago, we were basically told you can't give somebody too much oxygen. Well, we have found out since then that yes, you can. A couple things about oxygen and giving too much of it. The stuff that you breathe in and out every day is 78% nitrogen, 21% oxygen, and 1% other gases. That carbon dioxide was not mentioned in there. So basically, when you inhale, your respiratory system is completely carbon dioxide free. You only have carbon dioxide in your respiratory system when you exhale. So nitrogen, again, 78% of what you're breathing is nitrogen. Nitrogen keeps your alveoli open. All right. So if you start to bombard them with 100% oxygen, you are now starting to displace that nitrogen, and that's going to cause your alveoli to start to collapse. Well, that's not what we want, because when they start to collapse, then the exchange of oxygen and carbon dioxide is decreased at that point. All right. Also, oxygen can cause vessels to constrict when you give too much of it. Well, that's, again, we're kind of counterproductive there if we're constricting vessels with someone who's having a heart attack, because we're giving them nitroglycerin to vasodilate their vessels to try to get more oxygenated blood to the heart muscle. So you have to be very, very careful about giving too much oxygen. We don't want their oxygen levels to get up to 100%. All right, if we can get them up to 99, great, but don't let it get to 100, because the pulse oximeter will never go over 100%. All right, but when we get to the hospital, if we've been bombarding them with a non-rebreather for the last hour, and that O2 sat has read 100% for the last 55 minutes, when they stick a needle in their radial artery and start to draw blood gases, the oxygen content in the blood can be 4 to 5 times what it shows on that pulse oximeter. And that's going to cause those cardiac cells that are trying to die, that's going to cause them to die that much quicker. So you have to be careful when you give oxygen to someone having chest pain. Okay, so let's talk about heart failure. There's two different types of heart failure that you can have. You can have left heart failure and you can have right heart failure. The number one reason that someone has left heart failure is they have had a heart attack to that left ventricle. Okay, that's number one. Secondary is they have high blood pressure. All right, the number one acute cause of right heart failure is a pulmonary embolism. All right, the number one chronic cause of right heart failure is left heart failure. So I'll talk about that in just a minute. But let me look at these causes here and I'll explain, typically if you're having left or right, or it could be both. A heart attack, again, that's the number one reason you get left heart failure, okay, is an MI. Heart valve problems. Probably the valve problem that you're going to have most common is either going to be the tricuspid valve, which is between the left atria and the left ventricle, or your aortic valve. Well, the common thread with both of those valves is they deal with the left ventricle. All right. So again, you're probably going to have left heart failure if you have heart valve problems. Hypertension. Now, if you have systemic hypertension, meaning that when I come up and put a blood pressure on your arm and it's 200 over 100, then you're probably going to have left heart failure from that. But you can also have people who have what's called pulmonary hypertension. There's no way you're going to put a blood pressure cuff around a pulmonary artery and check their blood pressure. So how do you know if someone has pulmonary hypertension? They're going to have to tell you they do. All right? And they may not even know that they do. So what can cause pulmonary hypertension is typically people that have COPD, they're your prime candidates for having pulmonary hypertension. A pulmonary embolism, this is a blood clot that formed somewhere else and moved to your lungs. This could be a fat clot. This could be an air embolism that moves to your lungs. That's going to be right heart failure. Cardiac rhythm disturbances, that's most likely going to be left heart failure as well. Okay, so there we go. Okay. So this is what your normal cardiac output looks like here. This is your normal heart. You notice the left ventricle, the wall's a little bit thicker, but what's happened here? Man, that guy now has what's called left ventricular hypertrophy. What caused that? He's got high blood pressure, okay? That muscle has got to increase to try to overcome the pressure in that aorta, okay? That's just like if you're lifting dumbbells and you've been lifting 10-pound dumbbells for the last month, and now you're ready to graduate up to the 15-pound dumbbells. That bicep has got to work harder to lift that 15-pound dumbbell than it does that 10-pound. So this muscle, you see how thick it is. You see that ventricle can't fill up with as much blood as we can in a normal heart. So again, you're probably going to have left heart failure. And where's that blood going to go if it all can't be ejected out because this pump is so damaged? Where's it going to go? It's going to go back into your lungs, okay? All right, so we talked about right heart failure. Now, cardio, so let me back up just a little bit here, okay? And let me explain what I was talking about with left versus right and what causes left and all that. So hang on just a second here. All right, so let me just give you a prime example of left heart failure, and then we'll move on to this right heart failure. Left heart failure, all right, I'm sitting there watching TV. I start to have chest pain. I grab my chest and say, Elizabeth, I'm coming. My wife calls 911. They come out. I'm still having chest pain even though I'm at rest. I popped 2 nitroglycerins, 3 nitroglycerins before they got here. My wife gave me 4 baby aspirin. EMS gets here. My sats are 95, so I don't need any more oxygen. I've already taken my aspirin. I've already done my 3 doses of nitro. I'm still having chest pain that came on at rest. That's a 10 on 10. My left arm hurts. My jaw hurts. I threw up twice. So this is your typical, I'm having, a textbook MI. Now all of a sudden I start to have difficulty breathing along with my chest pain. Well, my left ventricle is now damaged so much that it can no longer pump blood out into the aorta the blood is now backing up into my pulmonary beds that lie outside of my alveoli. So I have a higher pressure in my capillary beds than I have in my alveoli. So that's going to cause the plasma to start to leak into my alveoli. That's going to cause me to get crackles or the pulmonary edema that's a result of this heart failure is going to result in me having wet lungs. Okay, and I'm going to get the crackles. Okay, so I'm not only having chest pain, but I'm going to be sitting up because I'm having difficulty breathing. And so EMS takes me to the hospital. They get me to the cath lab. They go, okay, we cathed you, but your left ventricle is pretty damaged. You're probably going to have heart failure the rest of your life. So I get to live with that the rest of my life because I have permanent damage to that left ventricle. Then I'm going to have to live with congestive left heart failure for the rest of my life. So I'm probably going to be taking drugs that make me pee more. I'm probably going to have some nitroglycerin that I need to take to try to prevent me having another big case of that pulmonary edema secondary to left heart failure. All right. So that's your typical left heart failure. Now, with right heart failure, I had knee surgery last week. I'm at home with a cast on my leg, and all of a sudden I start to have one-sided chest pain on my right side. I have a sudden onset of difficulty breathing. Okay, I probably threw a blood clot due to my knee surgery that I had last week. That blood clot has now made it to my right pulmonary artery, and now the right side of the blood of the heart is trying to pump blood to my right lung. Well, it can't because there's an occlusion there. Okay, so where does that blood back up? Well, it's going to back up into my jugular veins, so I'm going to get some jugular vein distension. Because the right heart receives blood from the rest of the body, and because it's starting to back up, then my ankles are going to be swollen, my liver's going to be swollen, my spleen's going to be swollen. So the blood is backing up into the system, whereas with left heart failure, the blood is backing up into the lungs. Okay, so very simple, guys. I hope this really simplifies this for you. Left heart failure caused by an MI, we have a respiratory issue that we're dealing with when we come across these patients. We are dealing most likely with the pulmonary edema that results from this congestive heart failure. All right, with right heart failure is a systemic problem where blood is backing up into the system, causing the peripheral edema in the ankles, the jugular vein distension, and the liver and the spleen to enlarge. So it doesn't really talk in the chapter a whole lot about how to treat pulmonary edema, but let's say that you went out on a patient today and their chief complaint was difficulty breathing. And so when you're doing your ample history on them, so are you having allergies? No, I don't. Okay, do you take any medications? Yes, I take nitroglycerin, and I take a drug called Lasix, which Lasix is a diuretic, makes him pee more. All right, what kind of history do you have? Well, I had a heart attack 5 years ago. Okay, did they tell you what part of the heart was affected? Yes, they told me it was my left ventricle, and they told me that I would have congestive heart failure the rest of my life. Okay, great. So this guy's sitting straight up. Sure enough, he's having difficulty breathing. You get your stethoscope out. You listen to his lungs on his posterior portion, and you hear crackles in the lower lobes of his lungs. Okay, this guy's got pulmonary edema secondary to his MI he had 5 years ago. All right. So what are we going to do for this guy? Well, there's two things we can do for this guy. Okay, as far as therapy goes, we can give this guy nitroglycerin. Nitroglycerin, even though he's not having chest pain. The reason that nitroglycerin will help with this patient is it's going to vasodilate all the arteries in the peripheries. That's going to decrease the amount of blood flow coming back to the heart. When you decrease the amount of blood flow coming back to the heart, that in turn is going to help decrease the amount of blood flow that's backing up into the lungs, and we hope that that is going to decrease that pulmonary edema that they have. And certainly we can put oxygen on them if their O2 sats are below 94%. Now, these people will want to sit straight up because, as we talked earlier, fluid is always going to be heavier than air. So make sure you sit them up as best as possible. And also when you sit them up, especially if you let their legs dangle, then that's going to help pull the blood down into their lower extremities as well, decrease the amount of blood coming back to the heart, and help decrease the amount of pulmonary edema that they have. All right. So I hope I explained heart failure, both left and right, to your little heart's content there. All right. Now let's talk about cardiogenic shock. This can occur with either left or right heart failure. So with left ventricular failure, you're going to have obviously a decrease in cardiac output, decreased perfusion. The systolic blood pressure is going to drop as well as the diastolic. They can start to have altered mental status because of the lack of perfusion to their brain, and then they can get respiratory distress due to the blood that's backing up into the lungs, causing the pulmonary edema. So with right heart failure, then the cardiogenic shock, which you may or may not even realize that they're in cardiogenic shock with right heart failure, can cause a decrease in lung perfusion. So this is, going to be the hypoxia, the respiratory distress, and so forth. So this next slide hopefully is going to make this crystal clear on what you're looking at on, does this patient have a left heart failure issue, a right heart failure, or both? All right. So let's look at the left-hand side here. Mild to severe confusion. This could be really with either one. Probably more likely with left heart failure, because what's causing the confusion is not enough oxygenated blood making it to the brain, and since the left heart's responding to the brain, then that's probably where the confusion's coming from. Cyanosis, remember, left heart failure is basically a respiratory problem, so that's probably going to be left heart failure. Tachypnea, or an increased work of breathing, most likely left heart failure. Cough up pink sputum. The sputum that they can cough up is not only pink, but it's frothy. So it's the air bubbles mixed with the plasma, and that's what's causing the frothy pink appearance to the sputum that they're coughing up. Again, more likely left heart failure. Low, normal, or high blood pressure. A lot of people think that low blood pressure goes along with heart failure, which it certainly can. But I would say every single patient that I saw that had a heart attack in the past, and since then they've had pulmonary edema, I would say every single patient that I had that we were treating strictly for pulmonary edema was actually hypertensive, or their blood pressure was high. Guys, it's just because of the sympathetic response. Again, you're having difficulty breathing, your sympathetic nervous system kicks in and increases the heart rate, increases the contractile force. That in turn is going to cause your blood. Rapid heart rate can be both. A desire to sit upright, that's most likely going to be more likely with left than it would with right. Anxiety is probably more likely left. Distended neck veins, now you can see that with both, but you're going to see it more prominently with right heart failure. And the way you check distended neck veins is they have to be at least a degree angle or a semi-Fowler's. Don't check for JVD if they're laying flat, because most everyone's going to have distension if they're laying flat. So they need to be at least at a 45-degree angle. If you check it at a 45-degree angle and they have JVD, and then you pull them up to a 90-degree and they still have JVD, then that's even more significant. Crackles is going to be left only. Shortness of breath is going to be left. Now, they certainly can get short of breath if the right heart failure is due to like a pulmonary embolism that was thrown, or if they're already short of breath due to the COPD or emphysema or bronchitis that they have. But if it's sudden onset of difficulty breathing without chest pain, then that's probably going to be the left heart failure. Pale, cool, clammy skin probably will be, could be both, I'm sorry. Abdominal distension, right only. And pedal and lower extremity edema, again, that's going to be right only. All right, so here we have Mama. She's got her little ankles that are swollen. So let me tell you that not all swollen ankles is right heart failure. Let's look at these nurses that are working in the ER these days. They're working 12-hour shifts. they don't get a chance to even take a break. They're on their feet 12 hours a day. I can almost bet you their ankles are going to be swollen at the end of the day. So if you'd like to, go ahead and poke your finger on Mamaw's ankle here, and when you pull your finger away, if you see a pit where your finger was, then that's called pitting edema. And the deeper that pit goes, the more blood that's actually backed up into the ankles. And here we have jugular vein distension. Again, they need to be at least a 45-degree angle for you to be able to assess that. Again, you can see this with left and right heart failure, but probably more prominent with the right heart failure. All right, so what do we do for heart failure? You treat it pretty much the same way you do as an MI. Again, we talked about giving the nitroglycerin and so forth, but with these folks, what can really help them out, especially if they have left heart failure, if they have the pulmonary edema that's associated with left heart failure, and you hear the crackles, rails, whatever you want to call it, you're hearing all that. If their blood pressure is at least 90, then it would be a good idea for you to get your CPAP out. All right. And remember, we talked about left heart failure. You have a higher pressure in your capillary beds than you do in the alveoli. So when you put CPAP on, CPAP is now going to cause more pressure in the alveoli than in the capillary bed. So you're hoping that CPAP causing that higher pressure is going to drive that fluid back out of the alveoli, across that alveolar membrane, back into the capillary beds where it's supposed to be. All right. So as we said earlier, about 75% of the people that have high blood pressure don't know they have high blood pressure. So what is considered a hypertensive emergency? Anything that's 160 or more systolic, anything above 94 diastolic would be considered an emergency. Now, one high blood pressure rating does not a hypertensive crisis make. All right, you need to find out, okay, what just happened? Well, my 2 children were shot and killed. Okay, well, they may have a good reason why their blood pressure is that high. So you guys will have folks coming into your fire stations, and they're wanting blood pressure checks every single day because they're probably fixing to either have a fiscal at work, or they're on a new blood pressure medication, or the doctor tells them to, or whatever. Make sure you have them come into your station the same time every single day and do the same thing before they get to the station. So just tell them, look, as soon as you get up, take a shower, do whatever you do in the morning, come to the fire station, get your blood pressure taken, then go home and eat breakfast and drink coffee. Because certainly caffeine can cause a change in your blood pressure. So have them do the same thing every day before they come in to get their blood pressure taken. All right. So if they're having a hypertensive crisis, they're probably going to be having a very strong pulse. The skin could be warm, dry, could be moist as well. They may have a headache. They may have some ringing in the ears, also known as tinnitus. They may be having some nausea, vomiting. Obviously, their blood pressure is going to be elevated. They actually can have seizures from this as well. They can get nosebleeds. There it is. Yeah, nosebleeds is listed up here. So, in the wintertime, we run our heaters when it's cold outside, and the heaters tend to dry the air out in your house. Sometimes that can cause nosebleeds, but if it's summertime and the air in your house is nice and moist, and now all of a sudden you have a patient that has a spontaneous nosebleed, first thing you might want to do is get your blood pressure cuff out and check their blood pressure. Now, if you have high blood pressure and it goes on for a long time, whether you just choose to not take care of it or you don't know that you have it, you can start to get some organ dysfunction, and you may actually die from that, probably later than sooner, but you can actually die from organ failure that's associated with your high blood pressure. All right, so there's not really much we can do. Even as paramedics, we can't really do much for this other than give them a drug to try to slow the heart rate and the contractile force down. But really just a position of comfort if they need oxygen, and give them oxygen, and then transport to, pretty much any hospital can take care of this issue. All right. So if they're in cardiac arrest, obviously there's no pulse, and obviously we would need to start CPR on these people. So again, the quicker you start CPR, the more likely you are to have a successful resuscitation attempt on these folks. All right, so if we need to give nitroglycerin, nitroglycerin is a very potent vasodilator that increases the coronary blood flow, but it also reduces the workload of the heart by decreasing the amount of blood flow coming back to the heart. All right, so you can assist the patient if they have their own nitroglycerin, whether it be tablet or spray. Again, when you're on the ambulance with medics, and they ask you to give the nitroglycerin that's either on the engine or on the ambulance, if they ask you to do that, then you can do it without having to call Viatel, because that's understanding orders with Viatel. Okay, so the systolic has got to remain greater than 90 for you to continue to give nitro, or no more than 30 millimeters less than the baseline to continue to give nitroglycerin. All right, now let me, this number has changed recently. Let me talk about these erectile dysfunction drugs for just a second. There's three out there. Probably the most well-known is one called Viagra. It was the very first one that was created. And then came along a drug called Levitra. You probably have not heard much about that because they don't tend to advertise very much. And then the newest one is called Cialis. Anytime you see a generic drug, all of these end in the word FIL, so Phil. Viagra is sildenafil, Cialis is tadalafil, and Levitra is vardenafil. So Viagra and Levitra, they work for about 4 hours. The Cialis can work up to 36 hours. So that's why that number had to change from 24 to 36 hours when Cialis came along. All of these drugs, well, I don't know about Levitra, but I do know that Viagra and Cialis are now generic form. Used to, one of these tablets were $100 a piece. You can get them for less than $10 a piece now that they are generic. So you're probably going to see a lot more folks taking these erectile dysfunction drugs. Don't think that only old guys with erectile dysfunction are the only ones taking these. The people that sell these on the internet, their prime target is younger people. So they don't have erectile dysfunction. They're using this for erectile enhancement. So all of these drugs cause vasodilation. So nitroglycerin being a vasodilator as well, you need to make sure you withhold any nitroglycerin if they've had any of these drugs in the last 36 hours, all right, because it can really bottom their blood pressure out. Now, one caveat to this, Cialis is the only one of the three that has been FDA approved for a condition that men get called benign prostatic hyperplasia, or BPH. Guys, as you get older, your prostate is probably going to swell, all right? That's just kind of inevitable. When it swells, you'll probably be the first to know because you're going to have a hard time urinating and you're going to be doing a lot of stopping and going and so forth. So they have FDA approval for you to take Cialis every single day, and that's going to help reduce the swelling of that prostate gland. So if you're taking 5 milligrams of Cialis every single day, obviously nitroglycerin is nowhere in your wheelhouse to give to this patient if they're having chest pain. All right, don't administer if the heart rate's below 50. If the heart rate's below 50, then they're probably too hypotensive to give nitro anyway, or if it's greater than 100. You can give up to 3 doses, 3 to 5 minutes apart, as long as the pain is still there and as long as the blood pressure is at least 90. Okay, so here's Papa. He's pretty typical. He's got his fist clutched across his chest. I'm sure his chief complaint was chest pain or something thereof. You see the EMT taking the blood pressure, make sure the blood pressure is going to be adequate to give nitroglycerin. She's calling in to medical control to see if she can give the nitro. She's checking the nitro to make sure it's prescribed to him. She's checking to make sure it's still in date. Now she's telling him to lift his tongue to the top of the mouth. She drops the tablet underneath his tongue. And be sure and tell them two things. You may get lightheaded from this. You may get a headache from this. And the third thing, and this is very important, this is going to burn. The first time I ever had nitro put under my tongue, it felt like somebody had put a lit cigarette under there. So it will burn under their tongue. This tends to not burn quite as much, but they can still get a headache from it. Blood pressure can still drop and so forth. With this nitro spray, like you see here, before you squirt it under his tongue, make sure that you squirt that, out in the air to make sure that the bottle is primed. So you want a nice full spray when you spray it under his tongue. And if that thing's been sitting in the ambulance for a while unused, it may just kind of dribble out when you do it for the first time. And then she's checking a blood pressure afterwards to make sure that the blood pressure stays above 90. She's going to be asking him, okay, your pain was an 8 on 10 when I got here. What's your pain now? Well, it's down to a 6. Great, we're heading in the right direction, but as long as your pressure is above 90 and as long as that pain is above 0, I'm going to give you 2 more doses of nitroglycerin. We're going to try to get that pain down as much as we possibly can. Pediatrics typically don't have heart issues that were brought upon by themselves due to their lifestyle. It's most likely something congenital or something that they were born with. Most children that go into cardiac arrest is due to some type of respiratory problem. So again, like we talked during respiratory, your BVM is probably going to be your best friend. Okay. So categorize your patients as either unresponsive in cardiac arrest, or they're responsive and they're in either minor, moderate, or severe distress. Obviously, if they're in cardiac arrest, we would need to begin CPR and put the AED on them. For the responsive patients, then we're going through our OPQRST and we're going through our ample history and all like that. So you go up to this patient. Again, here was the guy that was clutching his chest. You walk in and you go, sir, what's your chief complaint? Why did you call us today? I'm having chest pain. All right, now you're going to go through your OPQRST. Okay, what were you doing when that started? I was watching TV. Okay, the P for provocation or palliation. Does anything make it worse? Does anything make it better? No, nothing makes it worse. When I take a deep, does it hurt more when you take a deep breath? No, it does not. Okay, great. Describe that pain for me. Describe the quality of the pain. It's a real pressure type pain. It's like an elephant sitting on my chest. Do you take any, radiate. Does the pain go anywhere? Yeah, radiation in my left arm and into my jaw. Okay, on a scale of 1 to 10, 10 being the worst pain you've ever felt. What's your pain right now? It's an 8. How long has this been going on? That will get your time. It's been going on for 20 minutes. Okay, well, because of the way he presented to you, he most likely is having an MI due to the onset on how it came on, how long he's had it, that it radiates. It's an 8 on 10. So this is more indicative of having an MI versus having angina. However, the good thing about treating angina and an MI is the treatment's exactly the same. You don't really necessarily realize it's angina until you start giving the nitroglycerin and the pain goes all the way down to 0, then you probably have angina versus an MI. But the treatment initially is going to be the same for both. Do your secondary assessment. Again, there's your OPQRST that we just did. Ask them if they've had any contraindications to fibrinolytic therapy, and what that is. 20 years ago, before there was a cath lab on every corner like there is now, when we get somebody to the hospital, they would give them a medication that would actually dissolve a clot. Once it's already formed, it basically would turn their blood to Kool-Aid. We don't really do that anymore. We used to have a chest pain checklist. And we had all these questions we'd ask the patient to see if they were a candidate for having this clot buster given to them at the hospital. But now that there's a cath lab on every corner, they'd much rather go in and put a catheter in there and balloon them and then put a stent behind it. We don't really deal too much with fibrinolytics anymore. So treat this as cardiac compromise if the angina is lasting more than 20 minutes, if it's progressively worsening. Nocturnal angina means that it comes on at night while they're asleep. Angina unrelieved with rest or 3 nitros over 10 minutes, or chest discomfort lasting more than 5 to 10 minutes after they rest. Again, they're probably having an MI versus having angina if these things exist. Make sure you consider atypical presentations. Again, women, diabetics, older folks, those are going to be the more common atypical situations, and they may be having that silent MI. So here's where the pain can start, and here's where it can radiate throughout the patient. On your physical exam, obviously you're going to get baseline vital signs. Compare all your vital signs later on to your baseline, but check your pupils. Look in their mouth, check their necks if there's any JVD with their neck. Look at their chest if there's any scars there. If they've got the old zipper scar running down the middle of their chest, they probably have had some type of surgery done to their heart. Check their upper and lower extremities, so if there's any kind of swelling in any of them. Look at the back. Sometimes right above their crack, they'll get some swelling there as well, just like they do in their ankles, just like they do in their liver if they have right heart failure. And then check their vital signs. So we've talked about all these, but this one right here, this is a huge one. The feeling of impending doom. If they tell you they think they're fixing to die, they probably are. They have this innate feeling that things are just not right. And I know most of y'all are under the age, if not all of you are under the age of 62. But there was a show on TV years ago called Sanford and Son, and every time Fred got upset, he'd clutch his chest and say, "Elizabeth, I'm coming," thinking that he's fixing to die. Well, that's what the feeling of impending doom is if you think you're fixing to die, then chances are you are. And so it may not be a bad idea to have your AED very close at hand if they tell you that they think they're fixing to die. If they're in cardiac arrest, it should not take more than 5 to 10 seconds for you to check a pulse to ascertain that they truly are in cardiac arrest. So make sure you begin chest compressions as soon as you can. As soon as that AED is at their side, you go ahead and hook the AED up and let it do its thing. With the responsive patients, put them in position of comfort, do all the treatment that you need to do treatment-wise. Make sure you reassure them. Don't, tell them we're doing everything we can. We're taking you to the best level of care, so just reassure them as much as you can. If they have their prescribed medication, then you can help them with their prescribed medication. Again, you guys will be very fortunate that you'll have ALS with you there the entire time, so there's really not going to be any calling ALS for backup. And then reassess. Make sure that you reassess these folks because they can deteriorate pretty quickly. So it's never good to have a patient that was awake and alert in the back of your ambulance, and when you get to the hospital, they're unresponsive, and you didn't know it till you backed into the hospital, and then you realized it. So make sure that you reassess these patients. Just like you learn in patient assessment, every 15 minutes if they're stable, and every 5 minutes if they're unstable. Guys, that's a good test question. You probably see it on a test. 15 for stable, 5 for unstable. But in the real world, if you want to reassess somebody every 5 minutes, then that certainly is fine. So keep studying hard. Again, I've got my fingers crossed for all of you that you're going to do well in this class, and hopefully within the next month we'll be laying eyes on each other, and we can go ahead and do some hands-on stuff. So enjoyed it. Hope you enjoyed it as much as I did, and we'll talk to you soon. Thank you.